here's the deal with colorectal cancer. It is on the rise. Everyone asks me, well, what do you think? What do you think? Well, we don't know, right? We knew it used to be genetics. So genetics, you know, if you can't pick your parents, right, your genes, but that's really low, about 3%. So then, you know, environmental, food, and then really the biggest thing right now, why it's on the rise is because of early detection. So it's very, very important to get it early, because then it's curable. I mean, it's truly one of the cancers. If you're gonna get a cancer, we can cure you. So that's what's fascinating about this cancer. So here is a patient, not atypical of my day. I would tell you that our witching diagnosis, somebody that comes in the door, no matter what, they have hemorrhoids, right? No matter if they could be anywhere from anal cancer, rectal cancer, colon cancer, everyone thinks or assumes hemorrhoids. So patient comes in, you know, let's pick even earlier, because right now, men under 50, the rise is astronomical for colon rectal cancer. You know, insurance companies haven't caught up yet, so they still are in the old guidelines where 50, but because it's on the rise, detection is paramount. So a patient comes in, most commonly, they're doing okay, doc, I got some bleeding, I think I was told I had some hemorrhoids, I got some bowel habit changes. Well, I'm gonna be honest with you, the young people that I see with colon or rectal cancer, the thing that is really a tip-off is bowel habit changes. So we really gotta look into that.
Quick question.
Yes.
Is there a difference between male and female?
No, not really. So it's one of the cancers that's agnostic. I mean, they go either or. You know, it's consistently either second or third leading cancer. It goes up and down, but it's what is constant. It's the second leading cause of cancer deaths. And I'll be honest with you, the trend that I see lately, it's almost as if the healthier patients are getting colorectal cancer. Like I just operated on a 32-year-old marathon runner, eats like, gosh, amazingly well. All she had was loose stools. Somehow, multiple times. So back in the day, you came in with bleeding, you assumed you had hemorrhoids. No one would do a colonoscopy. Today, you gotta think, okay, it might be hemorrhoids, common being common, but you wanna rule it out. You wanna make sure it's not a cancer, so you get a colonoscopy. And it could be anywhere from just small bleeding, you know, bowel habit changes, or obviously, the bigger the tumor, the more, more symptoms, and also location. Location is very, very important. Right side versus left. Right side, it's kind of like the silent killer, because all you really present is, you know, you're kind of fatigued or whatnot, and your primary care doctor checks labs, and the next thing you know, you have a low hemoglobin or you're anemic. Well, that's the buzzword, get a colonoscopy, you have a big mass. Big mass on the right side, you're not seeing bleeding, you're bleeding kind of slowly internally. So it is one of those things where you gotta listen to your body, and you know, I don't want everyone to leave here thinking they got colon cancer. That's not my point, but my point is you gotta listen to your body. So right now, the key is early detection. So back in the day, they thought a polyp. So you got a polyp, you have 10 years for that polyp to turn into cancer. That is not the case. I've done surgery on someone who had a colonoscopy a year, 2, 3 years ago, right? So, and it depends. If you have a polyp that's aggressive, the job of a colonoscopy is to find a polyp and remove it. So if you have a colonoscopy and you find 10 polyps, well, that's a good day, because those are the polyps that could eventually turn into cancer. Here's the deal with polyps, right? So a polyp can be just a growth. So you have a hyperplastic polyp. So that's just normal. I mean, it's like almost like a skin tag, right? It just grows and grows and grows. Never ever will turn into cancer. Certain polyps will become, you know, kind of adenomatous, or the buzzword pre-cancer, right? So then all of a sudden, if that doesn't get removed, the cycle continues to grow, and then you become dysplastic, or really pre-cancer. And then if that continues to grow, then you have dysplasia or cancer. So you want to nip it in the bud before it gets into the cancer. So it kind of leads itself to, hey, here's a disease process that we can make a huge difference in if we detect it early.
What about CT colonoscopy? People talk about that, and I don't think it's as sensitive, but... Yeah,
so it's definitely gone down. Really, for us, or for most GI, a CT colonography, in fact, some institutions, it's hard to get, especially in the city. I think North Kansas City is one of the closer ones. And not every hospital does it. Really, the true indication for that is if you cannot do the colonoscopy for whatever reason. So women, so it's amazing to me that on my colonoscopy days, I can tell you right away, like I can almost pick, gonna be a hard colonoscopy. Ah, you're a dude, easy, hard, right? What's the theme? Women have very long colons, right? And when you have a long colon, the anatomy tells you it should be like a number 7. So you go here, here, and here. Women has done this, and you gotta try to snake. Yeah, you gotta snake the tube. So it's hard, it's very hard. And sometimes you just run, as they say, run out of tube, so you can't get to the end, so that's where CT colonography comes in. Really, I would never, and I get patients all the time, oh doc, I don't wanna do a colonoscopy, I've done a Cologuard, or I've done a CT. No. So even the company of Cologuard will tell you it does not replace a colonoscopy. Because if a Cologuard's positive, what's the answer? Colonoscopy. There you go. So it's a good in-betweener. Like if you had one 2 years ago and you're not due for another 3 years, but you're having weird symptoms, it's okay. I would say, okay, let's do a Cologuard. Now, the other thing is primary relatives. Like if you tell me at 25 your mom had colon cancer diagnosed at 40, then you would need a colonoscopy at 30. So primary relatives are very important. You know, grandparents, cousins, not as important, but also in the context of symptoms, right? You know, science is an art in practice, right? So you want to tie it all in. Like if you have risk factors here and symptoms, well, you get a colonoscopy. If you are totally asymptomatic and your risk factors are still low, I wouldn't tell you, hey, you need a colonoscopy. No. But the fact that you had one, that's good. But so then that also puts you in that category. So say you did have it last year and you're 26. Well, then you say, well, does that mean I'm good till I'm 45? Not necessarily.
He said I'm good till I'm in my 50s.
Right, so here's the other biggest misnomer. Are you ready for this? This is a misnomer. And then most GIs in the country are starting to adapt this. The reason why, so not only is colon cancer getting in younger populations, I am operating on older people. So last week I did a 91, an 87, and an 89-year-old. That's why I got no hair, right? Stress. But, so one would say if they had a colonoscopy 10 years prior, could they have had a polyp that was removed? They didn't need to see me 10 years later. But back in the day, the conception was, oh, you're 70, you don't ever need a colon. No one in this room is over 70, so we're going to say, if there was, and I bet you, I haven't been wrong with this, somebody.
He's already had colon. That's HIPAA violation.
Oh yeah, but no, my point is that no, but my point is that they'll say, oh, you're 75, you don't ever need a colonoscopy again. That's not true. The colonoscopy is a very low risk. So if you're able to tolerate it, you should have it.
So let's say I'm 64, I've had several polyps. I've been clearly polyps out of 50. So at 63, you had it, and you said, oh, you're good till 70. What is the interval that you think someone should have?
5 years. So here's a bias. You're talking to a surgeon, right? So I'm a colorectal surgeon. I do anywhere from 4 to 9 colon cancers a week, right? So my bias is, you can't, listen, I need you as my patient, but I don't need you as my patient, right? So my point is that,
I got plenty.
right. So my point is that a bias of mine is, I think 5 years is probably long enough. I never do 10. Now, if you're 80 or 75, and I did a 5-year at 80, and you had another one 85, probably done, right? Again, that's when you say risk to benefit. So I tell patients all the time, it's squeeze to juice ratio. How much squeeze to juice do I get, right? If you're 90 and you're pretty healthy and you have no issues, there's not a lot of juice there in doing a colonoscopy. So basically, stage 1, everyone always asks, what's stage 1, 2, 3, 4? So we all know 4 is really bad. So 1 and 2, it's in the colon. Stage 3, it doesn't matter about the colon, it's gone to the lymph nodes. So if you have a mass that's this big, but you have positive lymph nodes, it's stage 3. Stage 4, it's gone elsewhere. Basically, staging dictates survival, and the earlier stage, the more survival, long-term survival. So stage 1 colon cancer, I consider that a chip shot because guess what? I have a greater than 90% of curing them. There is not many cancers that you can do that. So stage 1, you detect it early, you come to me, I remove it, you know what, you're cured. That's amazing, right? That is not the case with lung cancer. That is not the case with pancreatic cancer. So with colon cancer, early detection can save lives, truly, truly save lives. So then as you go down, stage 2, you're at about 80%. Stage 3, that's when you start going to 70%. But here is the real crux. I'm giving you up-to-date data. Metastatic disease, in my day of training, you got metastatic colon cancer, they tell you, maximize your credit cards, don't worry about it in 6 months, right? Today, with chemotherapy, colon cancer is becoming a chronic disease. I have metastatic patients 10 years out. They're on chemo, almost like vitamin water, but they're on chemo. So guess what? That is where colon cancer, it's the hot topic because there's so much effort going into it because it is so common, yet it is also curative. So treatment of colon and rectal cancer depends on what it is. As I kind of alluded to earlier, colon cancer, you do surgery first. Depending on the pathology, if it's stage 1, 2, you're done. Stage 3, you get chemo, adjuvant chemotherapy. Rectal cancer, very important. Everything about rectal cancer is an educated guess. So we have to stage every cancer that anyone has, tongue cancer, brain cancer. Staging is paramount. So you have to stage because that dictates care and survival. So with rectal cancer, it is all about staging. And I have a passion for rectal cancer. I do probably more rectal cancer than anyone in this region. But it's staging. So what I mean by that is you do an exam, rectal cancer, it's low, you usually feel it with a finger, right? And then you also do endoscopically, so colonoscopy. But if it's a low tumor, you have to say, what is the chances of it going to the lymph nodes? Because that's truly what's going to dictate long-term survival. So if it's a higher T, so T1, the chances of it going to the lymph nodes, under 10%. Stage 2, you're in the teens. T3, you're greater than 50%. So the chances of it going to the lymph nodes is high. So why is that important? Because that means that treatment is needed up front. So you need chemo, radiation before surgery. So my typical rectal cancer patients, it's about a year. It's about a year worth. I see them, they get chemo, radiation up front. We're talking about 3 to 6 months. We wait 10 to 12 weeks. We do surgery. They get a temporary bag if I can reconnect them. That's another big question. If I can reconnect them, 3 months later, they get the bag closed. So that adds up to about a year. So the reason rectal cancer, more so than colon, is because with colon, you're going to take it out. There's no guesswork. You know what the pathology. The proof is in the pudding, right? Here we go. Rectal, I'm not taking it out because I got to make sure that I don't need upfront treatment. So that's where imaging is important. That is just, I can't even tell you how important. And it used to be ultrasound. In 2017, the transition went over to MRI. So the better MRIs you have, the better modality you have, the better you can stage someone and the better you can treat them. So colon cancer, you take it out, as I said, and then if it goes to the lymph nodes, you get more chemo. But the data is showing now that if we could somehow know that mass has lymph node involvement, it'd be better to give them upfront treatment. So it's kind of replicating rectal cancer. That's kind of new. So that's what's great about medicine. Everything is evolving based on data. So the colon cancer is evolving, meaning more people might get upfront treatment or before doing surgery as rectal. So with rectal cancer, again in 2017 we switched over to MR. MRIs, it used to be ultrasound. So ultrasound, again, what we want to find out is the T stage, the end stage. Because based on that, we say chemo, radiation, or surgery. So key. Ultrasound was not very good. It was 80% at best, but it was very, very, dependent on the tech, right, who did it. So then MRIs become the gold standard. So then you say, well, what better than to get the best MRI you can? So then you can really, I run the tumor board here. A tumor board is a multidisciplinary board with the oncologist, a surgeon, radiation oncologist, the radiologist, and that's where we review everything. It's like one huddle, we look at everything and make a decision. So that's where the MRI, the better the MRI, the better the radiologist can give me data, the better I can interpret that data and tailor a plan. So that's where T1, or Tesla, 1.5 versus 3 comes in. Here's the deal, as the take-home point. Colorectal cancer is preventable. It is curable. But if you do have it, if you get the best staging, it's the best chance of getting cured. And that's what we're here to do, cure cancer. It's pretty cool, right? Because not every cancer can do that. And what better than getting the best mode to do that with a great center, with an MRI. Truly, we are blessed to have something like this here.